Hello, everyone. We're going to get started. So my name is Ayah Nuriddin. I am a PhD student in the history of medicine at Johns Hopkins, and I'm also one of the co-organizers of this conference. Go team. I'm really excited to be chairing this panel, Incarceration as Healthcare. The finger quotes are really important. Because I think it's a really exciting, especially in light of what we've just seen with the films, which are a tough act to follow. It presents us with the opportunity to think about the ways that people historically understood incarceration as therapeutic, but also the ways in which people experience healthcare under incarceration. And then on top of that, what does it mean to be medically incarcerated and how that overlaps with issues of medical injustice? So I'm just gonna, whoops. Uh-oh. Sam, come hit the button. I know. It's always my fault. Okay, so I'm just going to talk like this. Our first panelist, I'm just going to introduce everybody really quickly, is Nancy Toms. She's a distinguished professor of history at Stony Brook University. She's the author of a number of books, including A Generous Confidence, which is a history of asylum keeping, and her recently Bancroft Award-winning book, Remaking the American Patient. I recommend it. All of you should get it. I'm going to also introduce Carolyn Sufrin, who is both a OBGYN and a medical anthropologist here at Johns Hopkins. She's also the author of Jail Care, Finding the Safety Net for Women Behind Bars. And last is Talila Lewis, who is an attorney educator and volunteer director of Help Educate to advance rights of deaf communities. And TL is also a visiting professor at Rochester Institute of Technology and the Gevelber Public Interest Lecturer at Northeastern University School of Law. So I will let them take it from here.
Right, put my timer on. After being at this conference for a day and a half, I kind of feel like an imposter getting up here. And I'm going to start by making the limits of what I know very clear. I have never spent a night in a mental hospital. And the closest I've come to a prison is 6 hours on Rikers, where I was treated like wrapped in saran wrap and only allowed to speak to the art therapists. So I come with limits in what I have to say, and I'm eager to hear from you and to connect with you about what you know. I would describe myself as a fellow traveler, of someone who's come to care a lot about what's going on and is still in the learning process. So we've seen today the power of documentaries. That's part of my story too, and I wanted to briefly mention to it again to call out the importance of documenting in so many ways. About 10 years ago, I started to work with a filmmaker named Lucy Weiner on this film about Kings Park Hospital in my backyard in Suffolk County, New York. Lucy was committed to Kings Park at 17 years of age. Back in 1967, she managed to get out, to recover, and she went on to become a filmmaker. So for about the next 20 plus years, she made films. She's probably best known for Rated X on the pornographic film industry, done a body of work on LGBTQ issues. But when she turned 50, she realized that she needed to make peace with that 17-year-old who had been in Kings Park. And she decided to make a movie about the history of Kings Park. Partly her history, but why it was there, and then what happened after it closed. So she needed a historical consultant. She called me up. And little did I know, in meeting her, I would start on a journey that would bring me here today. The last part of the film is shot in two places. One are a series of peer-organized and run support groups for ex-patients, peers, whatever you want to call them. And the other part of the film was shot in the Riverhead jail. So the kind of two polarities of our experience today. In working with Lucy and traveling with her to show that film in places all over, I've met people who've been involved in both the mental hospital side and the correctional side. That's why we went to Rikers, was to show part of the film to people there working with the they call them patients, the correctional officers call them inmates. And I've met many people like Lucy who are ex-patients who want to fix a broken mental health care system. And part of that brokenness is the use of correctional facilities to lock up people who have been labeled as having a mental illness. There are a lot of alums of Kings Park that are in the Riverhead Jail. I have a student in one of my classes now teaching a course on the history of the mental hospital, and he said to me, you know, my mom works at Pilgrim State. That's one of the facilities still open. My father works at the Riverhead Jail, and they know him by name. They send him back and forth. So one of the reasons I've gotten involved in this kind of event is to talk about the parallels between the rise of the mental hospital and the rise of the prison, but also the consequences of closing down public mental hospitals. You know it as deinstitutionalization, and what we need to think about in terms of decarceration. If we decarceration, what do we need to know about what went wrong with deinstitutionalization? What do we need to think about if we want to abolish prisons? What alternatives do we need in their place? And I think we can learn something by looking at the mental hospital side of the story. There are striking similarities as I've sat here today thinking about Kings Park was once the major employer in the town of Kings Park. People were sad to see it go away, in the same sense you have those Appalachian coal folks saying, yeah, we'd like to get a prison here because especially the less educated white people in town will now have a place to go back to work. So thinking about decarceration and deinstitutionalization seems like a good topic for this group. Now, you all are a sophisticated audience, so you have probably heard these statistics, but I'm just going to repeat them nonetheless. That the 3 largest mental health care providers in the United States are the jails in Cook County, Chicago, Los Angeles, and Rikers in New York. Not only does the U.S. have the highest incarceration rate in the world, but people with a mental illness diagnosis are 3 times more likely to be in a jail or a prison than they are in any kind of mental health care facility in this country. According to a 2014 study, an estimated 40% of individuals with a severe and persistent mental illness will have spent some time in their lives in either a jail, a prison, or some kind of community corrections facility. And again, as this audience probably knows, there is a very high correlation among symptoms of mental illness, substance abuse, and repeated incarceration. So you just start with that, and then you add on the effect of the brutalism that we've seen over and over again, and in especially in that last documentary. And you imagine someone who even had a shred of mental balance, that's going to be destroyed when they are incarcerated. You see, it's important to talk about these issues together. Now, there are a lot of worms in this can, and I'll be happy to take questions. Let me just start by saying, and Kate Hudson did a lot of good work for me in what she pointed out about the problems of experts and science. That also goes for diagnosing who's mentally ill as opposed to who's not. A diagnosis of mental illness is always a political as well as a cultural statement. We know that definitions of who's crazy and who's not are deeply inflected by all the, I did it too. It's something about pressing that. The intersectionality, race, gender, class, age, ethnicity, on and on, all figure in who gets labeled mad versus who gets labeled bad. You can have elderly white men with orange hair who have florid cases of narcissistic personality disorder, who are running our country, and someone with a much milder case who's poor and has a different skin color, who's going to be doing time somewhere. Clearly, these kinds of issues affect how we perceive the problem in the first place. So I don't want to diminish all the cultural factors that go into who ends up going into a treatment facility as opposed to a prison. There is indeed a lot of overlap. It carries some of the same kinds of consequences as well. If you have a mental condition and you are judged to be a danger to yourself or others, it's the only medical condition that I know of that justifies involuntary confinement and treatment. If you have cancer or diabetes, you can refuse treatment. If you have schizophrenia and are, again, judged a danger to yourself or others, you cannot. Being labeled crazy carries with it permanent stigma. Even compared to people with other kinds of disabilities. If you have a psychiatric diagnosis, you're going to find it harder to find housing and employment because you have this mental label. And on top of that, add the fact that many people with a severe and persistent mental illness turn to alcohol and drugs for relief from their pain. They self-medicate. The slang term for this, comorbidities or dual diagnosis, is you're in double trouble. Not only do you have the stigma of the psychiatric diagnosis, you also have the stigma of being an addict. And since the 1980s, when addiction was clearly redefined as a mental disease, the mental illness and addiction that link has really tightened up. And it's certainly a problem, again, that long preexisted the current opioid epidemic, which is getting all this media attention, again, because the people with the problem are white and middle class, but that's a problem that's been around a lot longer. Then comes triple trouble. You get arrested. Maybe it's for a minor crime, vagrancy, shoplifting, trespassing, drunk and high in public. Maybe it's for a major crime. You push somebody in front of a subway car, or you get a stick and you wave it at a policeman. If you survive arrest, and 25% of people shot during the course of an arrest have some kind of psychiatric history, you're in triple trouble. You're labeled mentally ill, you may be addicted, and now you're a criminal as well. I don't need to tell you how bad correctional facilities are in dealing with any of these kinds of issues. I'm going to assume you know that and hop over to the now what do we do? Can we talk about alternatives? And I just want to end by saying we need to, in my opinion, we need to think carefully about options that think simply that diverting someone away from a correctional facility into involuntary treatment is always going to be a good thing. There's a civil war going on in psychiatry as well as debates in correctional facilities over what it means to treat someone. Is it to put someone in essentially the equivalent of solitary confinement and bombard them with a suite of drugs that have been heavily promoted by the pharmaceutical industry? Is that treatment, or is treatment what ex-patients and the more patient empowerment movement is a more what community mental health care should have been, and what the ideal was. Supported housing, supported living, a kind of community approach that doesn't rely just on locking people up in another place and slamming them with a lot of psychiatric drugs. So harm reduction models can be used to think about how we might do things differently in this case as well, moving away from the idea of just giving people a pill and instead looking at the kind of support networks we can and do need to be. If you think about the harm reduction model as it's being proposed in addiction and HIV treatment, the call for the non-judgmental, non-coercive provision of services and resources to people who use them and the communities in which they live in order to assist them in reducing the harm. In recognizing the reality that poverty, class, racism, social isolation, past trauma, sex-based discrimination, race-based discrimination, and inequality affect both people's vulnerabilities to and capacity for effectively dealing with both mental distress and drug-related harm. And you do not attempt to minimize or ignore the real and tragic harm and danger that are associated with these conditions. I hope in the later discussion we have, we can look at some of these issues and maybe see how to connect some of these trends. Let me just conclude again by thanking the people for getting me here, and particularly Sam and Ayah, who I know are very concerned about these issues as well. Thank you.
So I also want to begin with a disclosure identification and acknowledging that I, too, have never been incarcerated myself. But I have spent a bit of time in jail providing health care. I am a medical anthropologist, and I'm also a physician. And I provided obstetrical and gynecologic care to women in the San Francisco jail for nearly 7 years. And my research grew out of those clinical experiences. And after just a few months of working as a physician in the jail, I was quite overwhelmed with the complexities, as well as my own complicity, of providing care in a space of punishment. And that enmeshment of care and violence in the same place was deeply troubling for me. I'm sure much more so for the patients I was taking care of. And it also, it led me to many other questions, and it gave me the sense that there was something bigger going on in the exam room and the clinic where I was stationed, besides just doing exams, prescribing medications, listening to fetuses' heart rates, measuring how women's pregnancies were progressing. And so that's what's led to the research that I'm going to talk about today, and some of the perspectives and troubling things that came out of that, both the findings but also our positionality. And when we find troubling things about mass incarceration that maybe are not about the typical narrative, what we do with that as people who also care about revolutionizing the system. And so I want to start out by telling you a little bit about a woman whom I call Evelyn, whom I first met as a patient. And she was 31 at the time, and she was in her second trimester of pregnancy, and I was taking care of her in jail. We had only 1 or 2 visits, and then she was released from jail. And then I ran into her on the streets, the 16th and Mission BART station, for any of you who have been to San Francisco, which I used to know just as the BART stop near my house. And then when I got to know Evelyn better on the streets, realized just what a different world it really is than what I thought, that it was, a very heavily saturated drug market, a lot of physical and sexual violence that happened just behind the doors of the single-room occupancy hotels around the station. But I ran into Evelyn there, and she was at that time 30 weeks pregnant, and she had a crack pipe that she was hiding behind her ear, and it was clear to me that she was probably high at the time. But what she talked about was, she asked me, where can I get some more prenatal vitamins? I'm worried about my baby. And this contradiction, what some people might see as a contradiction, which she's smoking crack, but she's asking about her baby. That is part of the contradictions that I saw in healthcare in the jail. Well, 2 weeks later, Evelyn was back in jail, and she said to me, she actually said to me that she had turned herself in to the police on the corner of 16th and Mission. She said, I have some outstanding warrants, which she did. But she basically turned herself in. She wanted to go to jail. And she said to me, everyone says I got arrested, but I got rescued. I was so sick, I didn't want to get high no more. I just wanted to be in jail where I knew that I could eat, I could sleep, and that even if it's not the best of medical care, I was going to get some type of care. This is deeply unsettling. For Evelyn to say that she wanted to go to jail, it is still jail. It is the San Francisco jail, and relative to other jails, conditions were relatively better than many other jails, but it is still a place of punishment. It is still a place of violence. And yet the conditions of Evelyn's life on the streets were such that jail in comparison felt safe. And importantly, this was where she knew she could get prenatal care. And this brings up a point actually that Nathan introduced the whole conference with yesterday, and this phrase that he said almost in passing, but I found deeply compelling. He said that prisons and jails provide a fugitive sustenance to people inside. And that is the troubling contradiction, right? They sustain people. And this is part of what this conference is about confronting those uncomfortable realities of mass incarceration. And so the fact that Evelyn felt cared for in jail, albeit with the constraints, it's more diagnostic of the larger relationship between mass incarceration and what's happening behind bars, behind the walls of jails and prisons, and the broader safety net in society, and how our safety net, if you want to call it that, cares for and doesn't care for people, especially women on the margins of society. And that mass incarceration is not just a political, economic, and racial control strategy. It is all of those things. But it is also about how mass incarceration and those forces are instantiated in people's everyday lives. And we saw some of that in the films as well. And so my work as an anthropologist, my main tool is ethnography, which is a methodology that involves observing, being part of a community in the ways that you can, but immersing yourself, talking to people, but not only listening to what they say, listening to what they don't say, listening and observing who talks to whom, who doesn't talk to whom. What do people do? What are their gestures, their eye movements? And anthropologist Lorna Rhodes, there are many people who have summarized what ethnography is, but I find her description quite apt. The ethnographer's work is to notice gestures, to listen for convictions and hesitations, to see gaps and ruptures in the smooth surface of appearance. And so part of this conference, too, is to talk about methods and what methods we can use to understand, to intervene, to act. And part of what I want to advance in this talk is that ethnography is an extremely powerful tool, but also a fraught one for advancing change and changing the system of mass incarceration. But it's these gaps and ruptures that lead us to the contradictions like Evelyn wanting to go into a space of punishment, into a space of violence. And what this also led me to see was, I was just positioned in a jail because that's where I happened to start working as a physician. But I quickly learned as I got to know women like Evelyn that jail is quite different from prisons. And I think all of us in this room know the basic differences. But in larger conversations, they often get conflated with each other, and even in the last day and a half. And they are quite different. And jails are not far away. They are not in rural areas, unless you're in a rural county, but they are located in the communities where people get arrested, which is usually where they live, although not always. And that connection, that geographic proximity, that spatiality, that tells us about the connections between jail and the community in ways that we cannot ignore. And that is why thinking about jail and seeing what happens in jails is diagnostic of the larger safety, of the problems and failures of the larger safety net. And so my entry point as a healthcare provider was this paradox, was not only my own experiences, but this paradox that incarcerated people are the only people in our country with a constitutional right to healthcare. Let that sink in for a moment if you didn't already know that. And that comes from a Supreme Court case in the 1970s, and Thurgood Marshall said that the deliberate indifference to the serious medical needs of prisoners is basically cruel and unusual punishment. Now, this was great. From this moment on, prisons and jails have been constitutionally mandated to provide health care. However, those phrases, deliberate indifference and serious medical needs, exactly, who defines it? Now, some of the attorneys in the room might say, oh, but there are constitutional standards that have been established in the court. I can tell you, as a physician in the jail, there are no standards. There is no mandatory oversight. There are no mandatory standards. And so there's tremendous variability in the healthcare that exists behind bars. At a place like the San Francisco jail, where there was a little bit more of a broad vision of public health and healthcare, services were relatively good. But at jails and prisons across the country, and I'm sure some of the people in this room who have been incarcerated can tell you, there is neglectful care that is dangerous and harmful. And so to understand how this right gets instantiated, we have to do ethnography and understand what happens, how people adjudicate this right to health care. And what I came to see is that as nurses, as doctors, as nurse practitioners, adjudicated and triaged people's health complaints in jail, it really was about the tension between the state's responsibility to care, especially for its most vulnerable citizens, against the the people's assessments of the moral deservingness of the person in front of them. And that tension between the state's burden to care and moral deservingness, that gets played out throughout society and through all kinds of discussions of the safety net. But because our safety net is broken in so many ways, you get people like Karen who say, you know, I appreciate when I do get arrested because I get my health back together. Most of my medical care is taken care of in the jail because, well, for the last, 10 to 13 years, I've been incarcerated more than I've been outside. So for Karen, this was the only place she got medical care. And apropos a comment that was made earlier, some of these people, as she said, she spends more time in jail than she spends out of jail, and it's an expectation that they will be back in jail. So this is just a picture of the San Francisco jail, the women's jail, and it's right next to the highway. It's right embedded in the city. And so I want to just take a moment in the few minutes I have left to tell you about another pregnant woman whom I call Kima. I also first met her as a patient and then further as a research, as part of my research. And for Kima, she actually first learned about her pregnancy in jail. She got a pregnancy test when she first came to jail. And it was a very emotional moment for her, in part because she actually knew she was pregnant, but she described feeling bad about using drugs and not taking care of herself. And so when she finally got the medical confirmation of a positive pregnancy test, she described how she just let it all out and she was crying. And this happened in the intake jail in a small room with a nurse named Charlie, whom she had known for almost 15 years. Because Kima and her attorney had counted that she had been incarcerated 82 times between the ages of 18 and 31, which is how old she was now. And so for Kima, she actually felt a measure of comfort in jail, of learning about the pregnancy, and felt at ease. And this is where, again, ethnography and understanding what happens on a day-to-day basis can tell us a little bit more about a phenomenon like recidivism, which gets talked about in statistical terms, right? The percentage of people who return to jail or prison after getting released. But what I observed through the frequency of people like Kima and Evelyn and Karen who came back to jail so many times, and the familiarity they had with the people who worked there. And sometimes they had sometimes there were caring relationships. They would play cards with the guards. At the same time, the guards would yell at them, tell them when to line up for dinner, and treat them in horrific ways. But they also were very caring. And then this played out in the way that motherhood is enacted in jail. And jail, this particular jail, was a very contradictory place to be a mother and to be a pregnant woman. So Kima gave birth while she was still in custody. And there were many ways that the San Francisco jail actually cultivated her sense of maternal identity. She had more medical care than she had on the streets. And in fact, she had prenatal visits every 1 to 2 weeks, which is actually more often than on the streets, in part because the healthcare providers knew what her healthcare access was on the streets and wanted to see her more often. I recognize this is not the case at every jail in the country. There were special privileges of being pregnant. You got a bottom bunk, you get extra food. They had parenting classes. This jail also facilitated visits with her newborn after she gave birth. She was able to breastfeed and pump breast milk for her mother. And importantly, she had walls that she did not have outside of jail. And on these walls, she could hang pictures of her and her baby. And she would actually leave pictures with other people she knew were going to be in jail for longer periods of time, because she knew she was going to come back and she didn't want to risk losing the photographs on the street. Now, on the other hand, at other jails across the country, there's neglectful prenatal care. At this jail and other jails, the jail workers and other incarcerated women have a lot of judgments about who is a worthy and unworthy mother. And at many jails, people are denied access to abortion. Women are shackled in childbirth in at least 28 states. That is perfectly legal. And most of the time, women are separated from their newborns immediately after birth. And so in all of these ways, motherhood is also tremendously denigrated. And of course, these are disproportionately women of color. And this represents a historical legacy of the suppression and denigration of poor women and the reproduction of women of color. In closing, I've only given you a snapshot of some of the contradictions of motherhood and care behind bars, but I think what it brings up is what do we do when we have troubling findings, like people wanting to be in jail, even knowing that it is a place of violence, a place of punishment. And while, of course, I do believe that it is diagnostic of the broader failures of society and of the role that mass incarceration has come to play and how inserted it is into the everyday workings of our society, into the replication of institutionalized racism, how do we use this for advocacy, and how do we advocate for change? So I'm going to leave that hanging as a question because I don't have the answers. But ethnography is a powerful tool for understanding the everyday lived experiences of people's reality and what mass incarceration is about for people. Thank you.
I'm just going to ask everyone to take a collective breath with me if you're feeling like you're up for that. I think that's what I need in this moment, so I'm going to invite everyone to join me if you feel so led. Thank you. First, it gives me great honor to name and honor the indigenous and native peoples whose unceded land we presently occupy. So I want to uplift the names of the Piscataway Nation and also the Haudenosaunee Nation. Settler colonialists might recognize the term Iroquois, but that is not accepted by the Haudenosaunee peoples. Second, I'd like to thank the organizers of this conference. I had a great deal of content prepared, but I'm feeling led to divert a little bit. Before I continue, I want to honor also and uplift the names of Freddie Gray and Corinne Gaines, both of whom are from this area and who were killed by law enforcement. Murdered, killed. Yes, call it what it is. I also have to uplift and name what we don't often name, which is the fact that both of these individuals are not just Black, low-income folks who the police accosted time and time and time again, but they are also Black disabled people. And with that comes the next truth that I will reveal, and that is over half of the people murdered by law enforcement annually are also people with disabilities. The percentage point is usually this 50% because we're doing crowdsourcing of murder by police because our government is not tracking. No one seems to know, not just how many folks are disabled, but also, indigenous roots of many folks get erased, income levels, et cetera, get erased as well. But disability is almost always erased from these narratives about who police are killing. And so erasure is actually a form of violence. And I spoke to this concept of violence a little bit yesterday about our own erasure here in this space. Many people don't know that Emmett Till also was Black and disabled. Emmett Till was murdered by white supremacists almost 60 years ago now. But this erasure happens not just in our advocacy. So often racial justice advocates and economic justice advocates erase disability, but also in our casework, whether it's medical casework or legal casework. In the legal profession, it tends to be very linear, right? You have to choose one identity or the other. You can't choose, being Black and female was the reason why you were discriminated against in the job setting. You have to pick one, right? And that's how the law operates, particularly linear, particularly anti-intersectional, particularly anti-Black, particularly anti-disability, anti-low or no-income community members. I want to define a term really quickly. Ableism or disableism. I think it's interesting that at this conference over the past 2 days, what's brilliant is that most of you all are doing disability-centric work already. You just don't name it as such. And so prison abolition work, harm reduction work, when done properly, with decarceration and pro-disability and pro-Black and pro-low, no-income and pro-trans at the heart of the work is good work. And so I must uplift that most of you are doing pro-disability work right now. Disableism or ableism. Disableism tends to be used more in Canada and the UK. Ableism tends to be used more here in the United States. I can get into the differences in them, but in general, it's a system similar to other systems of oppression, a system that decides who's valuable or worthy based on their appearance, based on their ability to produce, excel, comply, behave, right? And so what we found with a lot of police murders is this idea that a person should be able to respond instantaneously to some perceived command from some authority that they've, knighted themselves with, right? The fact of the matter is that most of the all of the DSM, and let me go back a step. Mental health is not what most people think it is. Like, mental illness is not what most people think it is. And I think even in the conversations that I've heard over the past 2 days, there's a lot of conversations about who needs to be incarcerated, what reasons they might need to be incarcerated. And disableism is actually, and ableism is really what's behind a lot of these conversations. The idea that disability is in some way inferior, the idea that speaking and listening with our ears and speaking with our mouths is some way superior to sign language, some way superior to folks who might type to communicate. All of these are based on very white supremacist, ableist, sanist standards. The idea that a person who's a person of color who's experienced a great deal of violence and trauma, that person should react in the same way that a white person might react to law enforcement, obviously very ableist and sanist as well. But I think this concept here is what I try to put forward when I explain to folks the fact that we will never get rid of mass incarceration without a disability justice lens. What we know is that people from every single marginalized community, whether it's trans communities, LGBTQI communities, Black communities, indigenous communities, women, what we know is that we experience disability disproportionately higher than the general population who does not belong to a power minority, is what I prefer to call us, right? And the reason for that is because the power majority has inflicted all manner of violence against us, whether that is perpetual poverty. Poverty is a form of violence. Extended stints in experiencing poverty leads to trauma. What we know is that a lot of our children in urban neighborhoods actually experience CPTSD, complex post-traumatic stress disorder. Not just that they experience PTSD, but it's a more complex version than veterans coming home from war, and that the percentage point is higher than our veterans coming home from war. That's this neighborhood right here, right? Like, there's this attempt to separate the violence inflicted on body minds. I don't separate the body from the mind. Separate body minds from the external factors that have afflicted us and our ancestors for generations, right? And that's a particularly white, ableist, classist thing to do because it feels better for white, wealthy people to be able to force us to internalize our behaviors, which are actually quite natural behaviors, to the pain and the violence that has been inflicted upon our body minds, right? So yeah, poverty is a cause and consequence of trauma. Trauma is a cause and consequence of disability, and the cycle never ends. And when you look at the carceral system, and when you look at how police, if you don't know the history, okay, there's so much history that's lacking in conversations about who law enforcement really is, what have they done to our ancestors, about what disability really is. I write about this in my piece called Disability Ain't for Your Dozens. I talk about the ways in which my ancestors were stolen from our land, and the ways that ripping our tongues, our native languages from us, what violence that inflicts on us. I talk about the Middle Passage. People often just, oh, it was a boat trip. If you understand what comes from months in the hull of a ship, and what that does not just to the body, but also to the mind and the heart and the spirit. And if you also understand history of what happened to my ancestors who were brought here and didn't make it here in their full selves, like whether that was in their mind, body, or both, they were literally labeled refuse by white people here, experimented upon, put into institutions that now we call prisons, and you need to know the history of the medical complex. Folks are throwing around the word institution and like correctional facility. What we need to know is that folks who were incarcerated who had intellectual disabilities, developmental disabilities, psychosocial disabilities, historically were housed in poorhouses. Before they were called poorhouses, they were called prisons. Yep. And the only reason folks were there was because they had no money, because they didn't look right, physical appearance. We had ugly laws here in the United States until the 1970s. Person couldn't be in public because they looked atypical, right? That's ableism, right? This is embedded in the roots of this nation, right? All of these things are missing in conversation. I know I'm skipping around quite a bit, and I think I only have about 2 minutes left.
About
Three. Thank you. I have to say that madness is such an important state of being. That madness is fluid in ways that most people don't understand. The problem with carceral systems and institutions is that the folks running them have never experienced madness. And madness for many people is hypervigilance, right? Many Black folks in this space, indigenous folks in this space, we know at every moment who's around us. That's not a problem. The problem is with society, how society perceives us, how that has now become an embedded policy that you can arrest folks for that. And I want to speak to something that you said, Nancy. You said you think mental health or mental illness is the only disability that allows for immediate arrest. That's actually not true. Buck v. Bell, a case in 1927, where the famed Justice Oliver Wendell Holmes said 3 generations of imbeciles is more than enough, that is still the law of the land. Folks with intellectual disabilities were being swept up and still are being swept up into carceral and, let's be clear, carceral and institutional spaces are one and the same. People who are in nursing homes, people who are in alternative schools, people who are in psychiatric wards, which again, previously were called prisons, and the persons in them called prisoners. Those are all institutions and they're all carceral in nature. We have what we call a burrito test in the disability justice community. If you can't leave your room at 3 a.m, put your burrito in the microwave, that means you're incarcerated, right? And in all of those spaces, you can't do that, which means you're incarcerated, right? There's no freedom. And so all of these things have to be taken into account. The last thing is that, let me just run through the slides and see if there's anything else from the slides I want you all to be aware of. Okay, well, this is cool. So defining disability. Props to Dustin for helping with this PowerPoint slide. Dustin is watching now. He's a fellow comrade in the disability justice and disability solidarity movements, right? There's a social model of disability and there's a medical model of disability. And what tends to happen in elite university academic spaces is that we focus on this medical model of disability, which says there's a deficit in the human being, that the deaf child must be fixed, as opposed to providing full and clear access to the child from birth to language. That the person who is hypervigilant because police should be arrested, as opposed to arresting the police for violating us all the time, right? These are the kinds of things that happen. So the social model of disability says that there is no problem within the person who is hypervigilant. The problem is within the external environment. Let's make sure that the space is safe or it fulfills everyone's needs in a meaningful way. Right? And so there's tons written on that. I suggest all of you folks read all of these great books. No one has mentioned any disability justice writers for the past 2 days in all the writings that you've talked about. We've got Mia Mingus, we have Leroy Moore, we have Dustin Gibson, we have me. I mean, there's tons of folks Lydia Brown, Autistic Hoya. I mean, tons of folks have been writing about these intersections for years. Karima Savic, I could literally just list them on and on and on. And if you haven't read any of these folks, you need to. A lot of our community members also don't write in the traditionally accepted academic way. And that should be respected, and we should be honored as sources, notwithstanding the lack of formal sources and citations. That's a huge problem in academia. And I see that my time is up, and so I just will give you my call to action. Stop calling the criminal legal system a justice system. Especially as people in positions of power, our language matters. And so long as we all know that the justice system is not just, so why would we keep perpetuating that myth? Lawyers, especially in this space, the Innocence Project lawyers, we got to cut that out of our lingo. Same concept is true with prisons. Call them prisons, not correctional facilities. I don't even know what that means, detention facilities. Get rid of that language. And the last call to action is to get rid of our language. We can't refer to Donald Trump as insane, all of that. He is a racist bigot, and you can say that if you'd like, but do not use sanist language. Do not use ableist language to describe things that aren't. So stop using the word crazy. If you don't, I identify as a mad person. I get to use the word crazy. I get to use the word mad. You do not. Right? If you don't identify as a mad person, please be mindful of your language in the same way that you are of other slurs. It is an ableist slur to use the word crazy, insane, or anything similar to reference anything other than actual mental illness. And we shouldn't be armchair diagnosing anyone. That perpetuates the stigmatization of people like me, people like a lot of the folks in this space, and you're actually helping the state kill us. So please cease and desist with that. And that's where I'll end for now. Thank you.
Right, now we'll have questions. Nathan could pass the mic.
Thank you so much for that. It seemed that when I'm about to give my presentation, everybody has already said what I'm going to say. But it's great what you say. I have a son who has Down syndrome, a 2-year-old cognitive scale. He's almost 50. And basically, the same thing, when I worked in this system, I find that people are always have a lot of persons who are incarcerated. But one of the things that I have to say to my son, one day he was just looking at a car. The police came. Somebody called the police that this black man is looking at a car. Police came. Were you looking for change? I know he did not know the meaning of the word change. Yes, they put him in jail. And so I had to go and I fought them right up to the level. I had the intellectual capacity to fight. I went straight up to the politicians and I went up to the police commissioner, and he eventually withdrew the thing. When I got the report from them, what they had was illiterate black male. That's how he was defined. So now what I do with my son, he doesn't live with me. He is in a home, to be an independent home. He calls me every evening from work, and he said, I had a good day. I said, remember, you see the television where the police arrest people and put cuff on them? Yeah. You want them to do that to you? No. So don't give any trouble. Don't talk. If you get mad with somebody, go talk to their house manager. That's the something, instead of telling the police who should be protecting. So what you said was right on in terms of what you said.
Can I just say something to that? So really briefly, we have to, and I didn't obviously get to a lot of the content, we have to understand that ableism is anti-black, right? And so what I mean by that is a lot of the criminalization of, so this era that we're living in is not just where black bodies have been weaponized, but disability has been demonized and poverty has been criminalized, right? And so if you understand all of these things together, and you understand that they always operate together, and you understand what the practice of intersectionality means, it means that your child is going to be hyper criminalized, hyper demonized, hyper weaponized, because not only is this person, and usually folks with Down syndrome are larger, more sturdy people. He's probably a large black male, right, who doesn't respond fast enough, right, and is probably being intransigent, right? And so all of these things work together, and if we're not addressing all of them, and also our carceral system, like literally over 80% of the carceral system, people with disabilities. So if you aren't saying disability and race, disability and gender, disability and whatever else, then we're failing. So we have to get into the practice of doing that. Literacy rates, 85% of the kids in our cages can't read above the 4th grade level. 60% of our adults in our cages can't read above the 4th grade level. But we also have to understand intelligence as manufactured by white people, right? By white wealthy people. We have to understand the eugenicists behind creating this concept of intelligence, standardized testing. All of these are just more means by which to further subjugate black, disabled, low and no income people. And if we're not talking to it in that way, then we're really missing the mark on how we address all of these issues. So yeah, I hope that makes sense.
I actually just had a quick question relative to the problem of collective action, and particularly related to the question of privacy. So thinking about the place that people live and work, and if they are, for example, dealing with mental disability or dealing with other kinds of health issues, and even thinking about folks who are formally incarcerated or serially incarcerated, it tends to be, and this was the point that Professor Murch had raised yesterday, a point of shame because of the social world. And so getting people to actually identify as being mad or identify as somebody who's come in serial contact with the carceral state is oftentimes very difficult as a first step toward even imagining collective action, institutional reform, and change. And so I was really curious, given across the three of you, what to do with, and this actually is a problem even in terms of the archive, because as I'm writing a story now that deals with mental hospitals, prisons, and other forms of incarceration, getting people to speak on and or document that experience is extraordinarily difficult, even from an archival standpoint. So I would love to have you all speak to the challenge of privacy and the specter of privacy as something that gets in the way of collective organizing, but also something that gets in the way of telling the stories that you all feel need to be told. Yeah.
Chair's prerogative, right? So just this question of privacy is something that I've come up in my own work, where I wrote a forthcoming article that Nancy is editing about the history of a segregated psychiatric hospital here in Maryland, Crownsville State Hospital. I don't know how many of you are familiar with it, but the sort of laws that are I had to go through the Department of Health and Mental Hygiene to get access to the records of the hospital because of concerns about privacy. But going through that process made me recognize that these concerns about privacy are less about protecting the privacy of the patients and they're more about protecting the liability of the state. And so this, like, the idea of privacy itself is so very fraught. And so even though I try to, in my work, not only, be legally, on top of what my IRB, a sort of approval, institutional review board approval, requires me to do, but also try to be respectful to the patients that I'm looking at and being respectful to the conditions and this, not only the medical conditions, but the social and cultural conditions that made them end up in Crownsville in the first place. And so this question of privacy, it's so fraught because the apparatus of privacy that we use, especially in the sort of medical world, is more about protecting institutions than it is about protecting people.
I don't know if I have an answer for the large-scale intervention necessarily, but this privacy, medical privacy, is something that comes up so much in how I navigate the dual role of being a physician and a researcher at the same time. And I worked very hard to separate those roles when I was in the jail and was very clear about not using protected private health information. But it turns out that, and no one was part of the research while they were actively under my care, but it turns out that all the women whom I encountered, they wanted so much for all of their details, and it's only these particular women. I'm not saying it's by any means universal, but they wanted the details of their births to be shared. They wanted people to know how their babies were taken away from them as soon as they were born. They wanted people to know what it was like to give birth in custody. They wanted people to know that jail was a complicated place for them. And the things that I tried to keep to the side and say, well, that's private health information, they said, no, you have to include that. And so, I'm now starting to sound like it's a simple matter of, what the people, what they want to share, and giving them the voices. I didn't even talk about the complexities of ethnographic research and the politics of representation. And here I am in a conference room in Baltimore telling stories of women who are still cycling through jail in the streets in San Francisco, and who am I to tell their stories? And they wanted me to, but there are limits to that. There are limits to what I can tell. And so doing more to give them platforms. The woman I call Kima is a very talented poet and very inspiring. And she, through another project, had some of her poetry published. Now that's not necessarily a strategy that's going to dismantle the whole system, but thinking of creative ways for people to decide themselves what kind of privacy they want and what kind of privacy they don't want.
This is TL speaking. A lot of the issues around that would be resolved if folks in the academy actually did research with and not on. Right? So too often it's folks who are not affected, who have all of the access to resources, and instead of spreading those resources to those who actually are affected. So for instance, Shorty mentioned during the last session, I love doing videography, that's my heart, but can't get the platforms, right? Because those platforms are, bogarted by folks who have privilege already. So figuring out how we can use that privilege and uplift those who are not in those positions. And so as a community organizer, I spend practically all of my time in prisons with incarcerated folks who are deaf and disabled. And I also spend time within the deaf community and kind of releasing the shame of and just having real conversations about real lives helps people just talk about it. So being in community is always helpful, and then also having community members in your space who are not just the check-off box, but who are leading these projects. So doing your research ethically. I don't actually do research. People are always asking me, what are your research? I was like, I don't research, I build communities. And so maybe we need to reframe what our research looks like and how we do it, so we're getting more genuine changes in the work that we do and in the way that our communities are perceived by those in the outside world. If that makes sense.
Thank you for your presentations, and TL, especially what you're speaking to really struck me as someone who's been medically incarcerated against my will at least 5 times. I don't know, I was trying to count, I couldn't. And I think one of the things that strikes me now as someone working at a predominantly white institution at a university in DC is that the kind of start of that experience, that part of my life, was initiated by a university. And I think we talk about these separate parts of like white supremacy is like this thing over here, and then it's connected to ableism, or it's connected to hypercapitalism. And you mentioned Lydia, and Lydia is the one who taught me this, and I consider them to be a great mentor. They're not connected, they need each other to exist. Like, they can't exist independently of one another. And so we talk a lot about the school to prison pipeline. Well, I mean, it was really literally what happened. I was a student at American University. I started experiencing crisis, and I trusted the institution to be there for me, but that institution wasn't built for me. I wasn't ever supposed to be there. There's like a quota, like, look, we have a token Black disabled woman who's also Muslim. This is great for us. It's like, we want to let you in. We're not actually here to uplift you or give you any of the resources you need. And so when I went to them with this crisis, it initiated a process that I didn't know about, but as someone who's a staff member at a university in the same city, I know what this process looks like. It's immediately notify the police, who will then handcuff you, be violent, and incarcerate you. And it's not just like you can't get the burrito. It's that you have a reinforced steel door in a tiny little cell where you're there alone and you're checked every 10 minutes. And if you're a Muslim woman who wears hijab and the only staff that they have are all men, you can't stay covered. It's that you're strip searched and you're not told why. It's that you're punished in so many different ways. And so I guess what I'm trying to highlight is that the kind of expansion of this carceral state is not limited to the very visible institutions that we've discussed, and institutions in air quotes, right? It's not just like the prison that's over there, or the jails that are in our communities, or the psychiatric institutions like PIW, which is where I was first medically incarcerated. It's also the schools. It's the universities. It's the top tier universities, those hallowed halls of privilege, right? It's those places that are set up as part of the white supremacist, hyper-capitalist, ableist system that seek to reinforce and further entrench all of these oppressive ways that keep folks like me fundamentally disenfranchised and unable to succeed. Because, like, I'm not equipped, and it's not because there's something lacking in me, which is what the medical model wants to argue. It's that I don't have any resources available to me in order to access them to be able to successfully advocate for those changes. And I was just trying to maybe connect to those in a more intentional way. But thank you again. I really appreciated those presentations.
This is TL. I want to honor you in this moment for your vulnerability and for sharing your truth. I also have been institutionalized, and yeah, it's much deeper than folks actually realize. And the folks who are saying things about how beneficial it is don't realize that I was starved there, right? Because everyone was so concerned that I needed treatment, but they forgot that I needed to eat, right? Like, the violence of institutions, if you've never been incarcerated in any setting, I think you should just not talk about how not violent they are, because you have no idea what happens in those spaces. And the second thing, what's interesting about being a person of color or a power minority at an institution is that usually the institution causes mental health breaks. And yet then they call the police to accost us and arrest us. And so that's something that should be named and something that we should all be addressing. I think most of us are academics, or at least tangentially related to a university in some meaningful way. We have to talk about, and I also write about the interconnectedness of, so like everyone can talk about like cis heteropatriarchy, but can't say, like, explain what ableism is. And if you can't do that, that means you actually don't understand cis heteropatriarchy, right? Or capitalism or anything else, because they're all literally Like, they're so connected that, like, they literally breathe and thrive off of one another. If you just remove racism, the rest of it still keeps churning because you haven't addressed all the other issues. If you just remove ableism, it still keeps churning because you haven't addressed all the other issues. This is why intersectionality, practicing intersectionality, is so critically important. The moment we start moving as one is the moment we actually disembowel all of these systems. And that should be the goal at the end of the day. Thank you.
Thank you so much for speaking at this event. I study and work in public policy, and I think discussing these issues in spaces like these conferences is really important and meaningful. But at the same time, I also realize that the time I spend in these safe, privileged spaces kind of takes away from the time I spend actually volunteering in jails or actually fundraising money to physically help the people that I write these papers on. So given that, I guess this question's for the whole panel, how do we as academics find that balance between physically meeting marginalized communities and then discussing them in academia?
That's a really excellent question, and I will be honest that that is something I think about every day, and how to, as you very eloquently stated, TL, doing research with, not on, as part of a form of activism, and a way to make the research meaningful, and doing doing something. It's okay to do research in informed ways, in ways that you've really beautifully highlighted, but to make it meaningful, you have to do something with it as well. And I hear what you're saying about how it takes time away from direct action, but I think there are also ways to think of them as more interconnected and not separate. The direct action, the spending time with people in the community, learning from them, and that is the action, and that's the research as well. And when you do, there are many different methodologies, of course, but taking that the data that you find and doing something with it. And I'll give an example just of recent work that I've been doing, and my collaborator Lauren Beal, who's in the audience. We actually have we know that there are over 211,000 women behind bars in this country. We know that most of them are of childbearing age. Most of them are already mothers. And we know that some of them, like Kima and Evelyn, are pregnant when they arrive in jail or prison. But we actually have no idea how many. We have no idea how many give birth. We have no idea how many have miscarriages, abortions, stillbirths, and other just basic health outcomes that we know for women in the general U.S. population. That absence of data, that these women don't count, that is a tremendous problem, and it is a source, a fulcrum for activism. And so our current project is actually collecting those data. It's not methodologically rigorous. We managed to get 22 state prison systems, the Bureau of Prisons, and then the largest jails in the country to report for 1 year every month how many pregnant women there were admitted, how many births, et cetera. But we're not just collecting these data and to publish them. We are acting. We are giving these data to community organizations, or sharing, I should say. We are working with people across the spectrum, although not everybody we should be, and I've learned so much from you about how to incorporate perspectives on ableism into dissemination and action. But we are doing something with them so that they will make change. And one of our sites already, Cook County Jail, they are just, I'm not saying it's a direct result of collecting these data, but just 2 months ago, their sheriff decided, why do we have pregnant women in their 3rd trimester in jail so that they give birth while in custody? And so they decided, they just changed their policy that any pregnant woman who is in her 3rd trimester in their jail is going to get released unless she is there on certain high-level charges. And they used the data that they collected for this study to say, this is how many women it would affect, and this is the effect it would have on our system, and they're not a threat to public safety. So that's an example of how doing the research and doing the direct action are inextricably linked, and so you don't need to think of it as taking time away.
And I would also add that we should be very mindful that if we're doing the research for pedigree only or for our IRB requirements only or for any of those things, we should really start to question our intentions behind the work that we're actually doing as well.
I'm speaking from the male perspective of the prison industry and the mental complex. I mean, with the women's health issues and things of that nature. Like Benny Starks, or I'm speaking about people that went to jail when I was a kid, all right, that been in jail for like 30, 40 years, that get released, that were used as test subjects for the pharmaceutical companies. We call it prison dumping. I'm gonna put you out so I ain't gotta pay for your health care. And then you dump them out on the street. And I deal with them every day because I deal with the homeless population. And they coming out of jail with no family, no support, no nothing. I mean, with all the studies that y'all do y'all do any studies on that? Because it's real prevalent here. I mean, I'm from Illinois, so Cook County, Lake County jails, that prison industry that they built up there, I came here on the interstate compact to leave that, but I'm right in the middle of that. You feel me? We just got a smaller version right here in Baltimore. But that prison dumping, because they'll even cut your time. If they can't afford to take care of you physically, they'll put you out. And they don't call nobody, they just put you out. And then y'all ain't talked about the bodies in the prison, that how much is you worth when you dead, that y'all medical facilities be taking up and using. You know what I'm saying? Unclaimed bodies is money. And we ain't talked about none of that. You know what I'm saying? There's a lot of money that's involved in this, and a lot of where it's involved with the prison and the mental health and the pharmaceutical companies. And when he was talking about the money trail, that's part of the money trail. And John Hopkins, I mean, y'all sponsored this, but y'all got to open up y'all's own pedigree and your own skirt and look up underneath it. Because a lot of your mental health stuff here is done here at John Hopkins. You know what I'm saying? I gotta be a skirt, though. I ain't going to tell you to drop your pants. I'm trying to be polite, politically correct, but those are the issues. You know what I'm saying? I was in Spring Grove Medical Hospital, all right? They took me out of lockup without a court order and moved me to a facility. And my lawyer didn't fight it. I didn't have a lawyer till like 2 weeks, 3 weeks after I was in Spring Grove. I tricked the media into coming to do an interview in Spring Grove. You feel me? Because that's how bad they wanted to lock me up. They want to say, oh, we got the crazy guy. But crazy people can't do what I do. I got them in there and I talked to them, and they asked you 405 questions, correct? Over and over again, right? I asked them one question. I asked them how to spell Waukegan, and they couldn't do it. You feel me? So that mental thing, they use that as a catch-22 in the black community. You feel me? Because if I can't get you for this, I can get you for that. That's that catch-22. And if I put you in this mental institution, I can hit you with a couple hits of this drug, and by the time I take you back to court, you drooling all over yourself and gonna say yeah to anything. And that ain't protected. That ain't even talked about, because them is unclaimed bodies.
So that is actually something that I'm trying to work on now, and I'd love to talk with you more about it. I'm trying to do parts of my dissertation, and some of the other work that I'm doing for my PhD is I want to look at not only Hopkins' role in this process, but like the longer history of how black bodies particularly have been subjected to human experimentation, and the ways that that happens in prisons, in mental hospitals, and on other kinds of carceral places, right? And the ways in which both living and dead black bodies are still exploited in all kinds of horrific ways. In my research that I did on Crownsville State Hospital, I was looking through death records that are publicly available at the Maryland State Archives, and you can see what happens to bodies, to people once they die. And there are a number of people who are, it just says on their public death certificate issued by the state, it just says removed, University of Maryland Hospital. And that means that you are now a cadaver for a med student without your knowledge and without your consent. And this is not a practice that's like over, right? This is ongoing. Right, you become, but it's not even just people who are incarcerated. It's not just people who are incarcerated, like medically incarcerated, right? Like the unclaimed body laws in this state also include people that are homeless. They also include, if your body is not claimed in this state in 72 hours, you become a cadaver. And then the flip side of that is there are other states that do not have these unclaimed body laws, and so Maryland, having a surplus, sends those bodies out, right? So this is an ongoing, it's both a historical and a current problem. I'm trying to do some stuff with it. I haven't figured it all out yet, but if anybody's got pointers, like, come holler at me, because, like, we got work to do.
We have to take just one more question before we facilitate another transition.
I have a comment and a question. I can't let the conference on humanities and incarceration go by without addressing kind of something that Shani brought up this morning, asking about the film and what was the filmmaker going to be doing to galvanize social movements and freedom movements, and something you mentioned about the poetry and kind of doing that little like shove off to the side about the arts that happens a lot. Like, I know it's not going to really do that much, but it's something, right? And I've done it myself in a community meeting where I knew the people I was talking to looked at what I did as being less than, as being, nice on the side. The arts are extracurricular. They're not really going to do anything. But note how you felt after you watched those films. Note how activated you were, how much you wanted to do something. I can't say how many times I've done a show with the community who've written it themselves, acted it themselves, came up with the concept themselves, and like decided what they wanted to say and how they wanted to say it, and have everybody go, well, what are we going to do now? What are we going to do? And creating structures for the community to develop those ideas. I just couldn't let that go by. That's my comment. This is really personal to me, and I've come to understand my ignorance about mental health issues over the last couple years as I got to know my aunt by marriage, Aunt Annie, who passed away just a couple of weeks ago. And she was really mentally ill and on medications, and in the past 4 months of her life had shut us out of her life in a very kind of like surprising way. I didn't understand what was going on. I personally didn't understand why this person that I loved and I knew loved me would shut me out like that. And before she died, in the previous few months, she was had her therapist call the police on her because she deemed a danger to herself and others. And the sheriff came. She didn't understand what was happening. She thought her therapist was coming. I also worked with a student who had that same thing happen, where I was directing her in a play, a young black woman at Cornell University. Her RA had discovered a Facebook message where she was expressing suicidal thoughts, and called the Cornell police, who came and handcuffed her and took her to, against her will, to the psychiatric floor of our little hospital. And my question is, because Steele, you were talking earlier when we were informally talking, just you and I, about these alternatives to incarceration and why the police are called to these mental health sites where someone is in need of assistance, is what can we do in our communities to develop a different policy, a different process for who gets called. If the 911 call comes in, where's the team that knows how to deal with this, that doesn't have a gun on their hip?
I appreciate you sharing about your Aunt Annie, and I think all of us have been touched in some way or another by mental illness. And I'll say this, you don't have to have a mental health break to have an emotional crisis and to find yourself in a situation with the police showing up, guns ready. And so this is something that we should all be particularly mindful of. What I found often in disability spaces that is deeply concerning to me is that the disability communities are generally run by very wealthy white people. And so they've been perpetuating the myth that training will be of some sort of benefit. It will not help. We've been doing it for 35, 40 years, and all the CIT training in the world obviously has not stopped police officers from killing people of color, people who are white with disabilities, mental illnesses, who are in emotional crises, etc. This is why abolition is critically important and why all of us being in conversation is important. What we know that is beneficial is divesting from more technology, more training, more of all of the same, and investing in community-based solutions. So trans-institutionalization really comes not just from the closing down of institutions and the setting up of more prisons, but also the divestment from, at that time, we had a lot more community-based programming and services. In this day and age, we have a lot of new apps that are coming up. So if I'm in a crisis, I press one button. Like there's several apps that have come out. I think most are created by anarchists, like Angel 5 or Angel 6. There's a couple of apps that it makes it such that you press one button if you're in crises. All of your friends get your location, get where you are, get what the issue is, and find you. They know better than to call police. So these are the kinds of things we should be investing in. Not doing more training. What training does is really absolve police officers after they've murdered people. It also is a form of victim blaming. We also have seen the rise of registries. A lot of the disability and deaf organizations have been pushing this idea that if we all just register, then the police won't kill us. I'm like, what cop do you know that has ever checked a registry before they killed someone, right? Like, that's not how this works. But a lot of money goes into that, like in Kentucky and California and North Carolina, where deaf people have been murdered as of late. That's what's going on, and all the money's going into that instead of figuring out where can we invest that money in our communities to make sure that we're keeping us safe with our own solutions. And that's what we should be doing, not just related to disability, but literally across the board. So if you're a white person and you're pushing registries and trainings and more technology so we can just record them killing us, like all of that's not helpful. We need to be looking at people like Miriam Kaba, who's at Prison Culture on Twitter, who's a longtime abolitionist from the Chicagoland area, who's been writing about all of this. Also, Zoe Zamudi, ZoeTSAMUDZI on Twitter as well, who's also an anarchist, black anarchist, abolitionist, femme black person who does amazing writing and work in this area, all with great ideas. So I appreciate that question, and I think the answer is stop doing what we've been doing and really start reconceiving of what we understand as justice and understanding crime as a social construct, as it always has been. And those are going to be ways to get us free. Yeah.
Thank you all.